حضراتكم التايتل of our presentation, it's the undifferentiated shock practical approach. If you remember, last week we presented part 1, بس just reminder للزملاء اللي ما حضروش معنا. Part 1 highlighted some shock pitfalls, then shock red flags, then we evaluated the cause or causes of shock with different types of shock, the common 4 types, then we added another 2, then we presented 2 case vignettes. Tonight, inshallah ta'ala, على موعد is for part 2, inshallah ta'ala, and by this part we could cover the undifferentiated shock. What we will present tonight, first is the bedside shock evaluation. Second, role of POCUS or point of care ultrasounds protocols and the undifferentiated shock, or to differentiate the undifferentiated shock. Third, we will answer the question which to choose to solve the hemodynamic puzzle. Is it dynamic or a static hemodynamic parameters, or both? And what's the evidence behind it? Fourth, we will answer the question when you face a critical ill patient crashing or he's hypotensive, then you want to answer this patient is fluid responsive or unresponsive. Then we will move to some hemodynamic management tips. We will conclude with the take-home messages as usual. Then, if we have time, just to brainstorm with the attendees 1 or 2 case vignettes like the first part. Just let's move to the bedside, or the first part of our objectives tonight, in second part of the undifferentiated shock practical approach, is the bedside evaluation of the shock or the hypotension or crashing patient. So this applies usually bedside, and it applies for evaluating patient with hypotension, undifferentiated shock, or if you can call it crashing patient. So if you remember from part 1, we have the clinical skills. Because at the end we are physicians, we are intensivists, and we are bedside. So usually we start with the clinical exams. From the previous lecture or part 1, we have an idea about the role of skin perfusion regarding the warm extremities or mottling or cold extremities, capillary refill time. Second, what's the data you got it from the overhead monitor, because now the crashing patient is already in the ICU, or he's in the ER, or he is in the floor, and you responded at that time for rapid response or critical care response team. So you connected the patient to the monitor, either non-invasive monitor or invasive monitoring. So what's the data? You will got it from the monitor to help you in differentiating the shock. Then combining the clinical with the overhead or the monitor data for vital signs, it can give you some clue. Then now, as far as most, I cannot say all, but at least most of the ICUs now, they have the bedside echo or the POCUS or the point of care ultrasound. We call it now, instead of stethoscope, the point of care ultrasound is supposed to be the standard of care, and we call it point of care in critically ill patients. So it's very difficult sometimes to manage patient in ICU and you don't have the ultrasound or portable ultrasound. It helps you for starting line insertion, guiding you the line insertion. Then you will use it, as we will see later, the role of point of care ultrasound. So if you grasp your probe of the portable ultrasound, we call it proboscope, like stethoscope. So you can assess with different views the bedside echo. I know that most of us, we are not echographers, we are not cardiologists, but at least we are talking about simple views, and point of care ultrasound, just it will help and it will guide you where you are. So it's an evaluation tool, very easy. You have to handle it, you have to be skilled, you have to have some expertise around you, or you have this experiences, and these experiences cannot be gained unless you practice every day with the probe. Either you have a practice the lung ultrasound or echo or abdominal ultrasound. So from echo ultrasound or from echocardiogram, you can assess the RV, the LV, the IVC, the pericardium, the valves. And it, of course, it will give you hence an idea, and I will show you later. Regarding the lung ultrasound, of course, using the probe to assess the lung ultrasound points, it will tell you where you are from pneumothorax or pneumonia or effusion or even pulmonary edema. Then you go down to the abdomen with the abdominal probe, and you will assess through EFAST or FAST exam. Then you can evaluate underlying cause of shock, and we will show you later how is the rule and how can you assess bedside with certain protocols, even if you are a trauma member or you are in the ICU or in the ER. So for patient who is hypotensive, you are facing him is crashing right now, and you want to know what's the cause of hypotension, what's the cause of shock, what's the underlying cause of this undifferentiated shock. You know that he's shocked now, as we had been taught in the last or in part 1. Now you want to know, and of course, the management will differ according to the cause. So again, now if the patient is hypotensive, as we remember, we have to start with clinical and physical exams, data from the monitor. Then you grasp the ultrasound to assess the IVC. You have a lock on lung ultrasound and echo. All of these data bedside, it will give you hint or clue about the type of shock and the underlying cause of hypotension or shock states. So let's move now to the point of care ultrasounds in the ICU or in the ER to delineate or to differentiate the cause of undifferentiated hypotension or undifferentiated shock. So either algorithm using protocols or both. So for delineating the cause of shock, it's challenging, and we know that it may be a single cause, or sometimes maybe overlapping, or you may have more than one type of shock. So not only simple septic, not only simple obstructive or cardiogenic sometimes. So what about the algorithm? If you want to apply certain algorithms, so this is a simplified algorithm adopted from an article review published in New England Journal of Medicine, very nice one, and I encourage everyone to have to download this review article about the circulatory shock. And if you want, inshallah ta'ala, I can send you the download link for this nice article, and I like it because it's an interactive article. So now if you would like to apply an algorithm or a simplified algorithm, putting in your mind that the common types of hypotension, or the common types of shock and its frequency. So if the patient now has hypotension, so the next after hypotension is to look for the presence or absence of signs of hypoperfusion. So first you look for the clinical signs of tissue hypoperfusion in the brain, in the skin, kidney, heart rate, and if you are lucky enough and you have serum lactate around, so now you combine 4 or 5 clinical data with serum lactate. So if the patient is hypotensive and he is having altered mental status, mottled or clammy skin, he's oliguric, he's tachycardic, or on the other side, he's severely bradycardic, and you have bedside or point of care VBG or APG to tell you about high lactate, more than 2, 3, 4. So this is a positive signs of tissue hypoperfusion. Now we have two signs. We have hypotension, we have tissue hypoperfusion. If yes, so now your patient is in circulatory shock. Now your rule is to delineate what type of shock, is it distributive shock, hypovolemic shock, cardiogenic shock, or obstructive shock. So next step is to estimate, if you have a tool, to estimate the cardiac output or the central venous saturation. If you have the capability or the tool bedside to estimate the cardiac output, and you measure the cardiac output or the central venous saturation or mixed venous saturation, if the patient have Swan-Ganz catheter, so the data now is in your hand. If the cardiac output if the cardiac output is normal, or the central ventilation is normal or high, so this is a state of distributive shock. You have a cardiac output normal or high, central ventilation normal or high, so this is a picture of distributive shock. If the cardiac output is low or the central venous saturation is low, so now the role of measuring one of the static parameters, which is the right atrial pressure, or people who likes the CVB. So and inshallah ta'ala, maybe in one of the lectures next in our calendar, we may present the role of CVB assessment and measurement and critically ill patient. Should you use? Should you prohibit? It is not in use anymore. So if you have the capability to measure the right atrial pressure, now right atrial pressure is either low or high. We have the patient now in circulatory shock, cardiac output or central venous saturation or mixed venous saturation is low, right atrial pressure is either high or low. If the right atrial pressure is low, so now you are talking about hypovolemic shock. If on the other hand, if the right atrial pressure is high, so this is either cardiogenic shock or obstructive shock. The next after that is the role of point of care ultrasound or the echocardiography. And with this echocardiography or with this tool, which is the focus of point of care ultrasound, if you have some expertise, you are able in most of the cases to delineate the common type or the common cause of this shock, either distributive shock with common causes, or hypovolemic with its common causes, or cardiogenic with its common causes, or obstructive shock with common causes. So we started, as you see, in this simplified algorithm, we combined the clinical data with hypotension, then we identify the state of circulatory shock, then we move and we escalate according to the tool that we have from cardiac outputs, intravenous saturation, right atrial pressure, and we ended up also with the use of point-of-care ultrasound. What about the protocols? Regarding the protocols related to the POCUS or the point-of-care ultrasound, I know most of you are aware about it, but just a reminder for you, what's the role of this protocol if you are using the POCUS or point-of-care ultrasound? The first protocol, and I think all you are aware about it, is the rapid ultrasound shock protocol, or we call it RUSH protocol. So RUSH stands for what? Rapid ultrasound in shock protocol. Second protocol, we call it FALS. FALS protocol is stands for fluid administration limited by lung sonography, FALS protocols. Third protocol, we call it the PLO protocol. PLO stands for what? Bedside lung ultrasound in emergency. This is, we call it PLO protocol. This is the third protocol. And we will end up with the fourth protocol, which is the COS protocol, who stands for what? Cardiac arrest ultrasound exam. This is during the CPR, because when you face patient during the CPR and you know why he is arresting, what's the cause of arrest? So the point-of-care ultrasound can help a lot to delineate the underlying cause of cardiac arrest, not only the shock. So now you have 4 common protocols: RUSH protocol, FALS protocol, PLO protocol, and COS protocol. Let's move to a reminder for each of these protocols. Regarding the RUSH protocol, for the RUSH protocol, you have to assess 3 main items: the pump, the tank, the pipes. We call it like this: pump, tank, pipes, PTP. Pump, remember, pump, tank, pipes. And I will highlight you what does it mean pump, what does it mean tank, what does it mean pipes. From the titles, pipes is the vasculature, is the ultrasound to assess the vascular tree. Tank is the abdomen, and it's contents. Pump is the heart. So through assessing those common 3, which is the pump, tank, and pipes, you can reach a diagnosis under each entity of assessing with the point-of-care ultrasound for pump, tank, and pipes. If you go with ultrasound to assess the pump and you found that the patient has hypercontractile heart, there is increased contractility, and there is a small cardiac chambers, LV, a small heart size. So this is with hypovolemic shock. If you move to the tank, then you assess the IVC. You found that it's a flat IVC. It's collapsing. And you assess the peritoneal fluid and pleural fluid as well. So this is goes with hypovolemic shock. If you go for the pipes, for the aorta and aortic dissection, and you assess for any of these findings here, if you have some expertise, your patient is thin, so this will give you the data or supportive data about the diagnosis of hypovolemic shock. While in cardiogenic shock, you will assess the pump, the tank, and pipes. On the reverse here, or contrary, you will find the hypocontractile heart, you will find dilated heart size. By eyeballing, you have low ejection fraction. You go for the tank, you will have the IVCs distended, and you may have some pleural effusion or some ascites if the patient have advanced heart failure. If you go for the pipes, here the aorta usually is normal. If you want to diagnose the obstructive shock, here we are talking about the tamponade or evidence of RV strain. Here you, by assessing the signs of RV strains, like RV dilatation, deviated septum, pulmonary hypertension, McConnell sign, this is, or sign 60/60. So these are signs of pulmonary embolism. Or you may find large pericardial effusion or signs of tamponade. And here you are assessing the pump, and this is give you an idea about it's a type of obstructive shock. If you move for the tank, you will have the IVC is distended, and if you move to the lung and you found that there is absent lung sliding, so you are assessing a pneumothorax absent or present as a cause of obstructive shock. So you assess the tamponade, you assess the PE, you assess the pneumothorax as the main causes of obstructive shock. If you move down to the pipes, so for example, in PE, you have to assess the femoral vein, the peteal vein, to assess if there is DVT present or not. While in distributive shock, like in sepsis or anaphylaxis, if you assess the pump, you will have the heart early in sepsis, it will be hypercontractile. Late in sepsis, because of sepsis-induced cardiomyopathy and low ejection fraction, you will have the heart is hypocontractile. Regarding the tank, the IVC either normal or small. You may move to assessing the pleural fluid or peritoneal fluid as a source of sepsis. You may find the pleural effusion with fat stranding or evidence of infection or empyema. Also for peritoneal fluid, you may have some evidence about the ascites or peritonitis. If you move to the pipes, usually are normal. This is how we use the Rush protocol in assessing or delineating or indifferentiating the cause of shock. And this is a very nice slide. I encourage every one of you to have this slide in your smartphone, just as a reminder how you assess the pump, the tank, and the pipes, and what in the pump, what are the view. If you are using the parasternal long axis view, what we will have, or if you will have the parasternal short axis view, what you are looking for. Because when you hold the probe in your hand, it's in your mind what I'm going to see, what I'm expecting to see. So if you are familiar with, of course, you will identify. For apical, for chamber view, what you are going to have. For subcostal, what you are going to have. The same for the tank, the same for the pipes. This is regarding the Rush protocol. And here for people who likes the algorithm based, this is how the assessing the pump and the tank and the pipes to delineate the most common types of shock for pump, for tank, for pipes. Under the pump, you have the four. What are the positive data that I would like from your side to know? Then you will tell me this is the most common type of shock. If you go for the tank, what you will assess through the tank by point of care ultrasound, and how can you identify the cause of shock or undifferentiated shock. Also the same for the pipe. So remember, for Rush protocol, you have the pump, the tank, and the pipes. While the second protocol, for people who are familiar with using the point of care ultrasound, we call it FALS protocol, or fluid administration limited by lung ultrasound, because many intensivists, they like to give fluids during the shock state. So this protocol is applicable or appropriate to use in shocked patients who presents to you, and you put the point of care ultrasound on the lung fields, and you have an A profile. And I will show you what's the A profile. So if this is the case, we call it false responder type. What about your endpoints, and what are the limitation of this protocol? For the endpoints of this protocol, prior to applying this, you have to use that we call Diplo Protocol. I will show you later. So for Diplo Protocol, from the Diplo Protocol, you can identify or you can diagnose the presence of obstructive shock secondary to tamponade or pneumothorax. For cardiogenic shock, you will have pre-profile on the initial ultrasound. When you have two common causes already either ruled in or ruled out. Then you have to now to administer the fluids and to either to give or not to give, to continue or not to continue. So for hypovolemic and septic patients, for hypovolemic, usually it improves after the parameters will improve after giving or administering the intravenous fluids. For septic shock, you may have B-profile and you may have some B profile and evidence of pulmonary congestion after IV fluids. So here you can identify 2 before and 2 with. But remember, each protocol is not ideal, has advantages and disadvantages or limitations. So the limitation for false protocol, patient usually when they present with B profile, they have a large or wider differential diagnosis. So B profile differential diagnosis, you may have cardiogenic shock, you may have diastolic heart failure, so either systolic or diastolic, or you may have pulmonary fibrosis. Either also the second limitation is that the cardiogenic shock with no lung edema, like patient presenting to you with right heart failure, acute right ventricular infarction, usually they don't have B profile, they have A profile, because this patient has acute right ventricular infarction, inferior MI with RV infarction. Usually they have A profile, not B profile. It's a cardiogenic shock, yes, but there is no lung edema. And these are the algorithm, how you use the false protocol. This is a very nice illustration, how you rule out, you start with ruling out first the obstructive shock, and this is using the simple assessment for ruling out pericardial tamponade or RV dilatation. So you roll 2 now, BE and pericardial tamponade. Then you move for lung sliding and you assess the pneumothorax through the Diplo protocol. Then now you ended up with obstructive shock. Then you move to the cardiogenic shock through the pre-profile. Then you move to assessing either hypovolemic or usually septic regarding the correction of the clinical signs of shock under after giving fluid administration. This is usually the false protocol, and as I told you, it has its own limitation. Again, this is we call it the decision tree or schematic decision tree, according to in patient with acute circulatory failure. After you apply both the Diplo protocol and false protocol to delineate the obstructive shock, the cardiogenic shock, the hypovolemic shock, and the septic shock. So you have to have in your mind where my probe should I start with, and what's are the data that I am gonna interpret to help me for delineating the common cause of shock. And this is the Diplo protocol, or the so-called, we call it bedside lung ultrasound in emergency. And this is, you start usually with assessing lung sliding either present or absent, and according to the lung sliding you move. Then if present, you assess the P or A profile, or its absence or presence. Then if absent, you go for the lung point, presence or absence. So you can identify from the Diplo protocol the presence of pneumothorax or pulmonary edema or pulmonary embolism or pneumonia or COPD or asthma exacerbation. So you have common 5 here through diseases can help you through assessing the Diplo protocol. So if you are familiar with this protocol, you can put on your mind in patient, especially with hypoxemic respiratory failure associated with circulatory failure. And here as I told you, this is what does it mean, A line or A profile or B profile. So A profile, it means that the lung is aerated or over aerated. This is the A line, it's a transverse line. This is a sign of aerated lung. When you have partially deaeration, so you have longitudinal lines now, we call it P lines, and according to its number. So here is the evidence of pulmonary edema or lung congestion. When it's completely deaerated lungs, so this is an area of consolidation. And here is, according to this very nice illustration, as far as you go through less aeration to consolidation, this is the role when exactly the point of care ultrasound through the Diplo protocol can help you to identify the cause, and also can help you to initiate fluids or to initiate furosemide or diuresis. And regarding the point of care, as far as we are talking about point of care ultrasound profiles, in assessing the role or the diseases, these are the accuracy of point of care ultrasound. Here, assessing the sensitivity and the specificity if you compare this to other tools. So for the common diseases or common entities like pulmonary edema, COPD, asthma, pulmonary embolism, pneumothorax, and bronchial pneumonia or viral pneumonia. So you have for the different profiles, you have a specificity approaching 100%. So the minimum, as you can see here, is 94% up to 100% specificity. Regarding the sensitivity, still it's highly sensitive, but still here with some profiles, especially in the pneumonia profiles. But again, if you combine, for example, here, as you can see, the 4 pneumonia profiles, so the sensitivity go up to almost 90%. So the minimum is 90%. In pulmonary edema, for P profile, you have a 97% sensitivity with 95%, for example, if you compare sensitivity and specificity. So again, here, the point of care ultrasound is highly sensitive, highly specific when you identify a cause of acute hypoxemic respiratory failure in patient presenting to you with circulatory failure. You're gonna decide to give fluids or not to give fluids. So you will not rely only on chest X-ray until you bring the portable X-ray. Patient is unstable to put the cassette to move him. While the point of care ultrasound is bedside, very simple tool. In 2-3 minutes, not more, of course, you can get the answer. The last protocol that I told you about, which is the cardiac arrest ultrasound exam or cause protocol. This is usually when you face patient which is asystolic or non-shockable rhythm. Usually we apply this protocol, remember, in non-shockable cardiac arrest. What's the non-shockable? Is there asystole or PA, pulseless electric activity? We are not applying this during the VF because the priority is for shock, giving the shock, then high quality CPR, then look for the cause. While for non-shockable rhythm, you continue with high quality CPR, giving the epinephrine. Then your rule here is to identify what's the common cause of shock. You are assessing 5 H's and T. They taught us during the ACLS when you face patient with cardiac arrest and you are doing CPR, you want to know what's the cause of his cardiac arrest. 5 H's and 5 T's. The point of care ultrasound can help you if you're especially familiar with using the cardiac ultrasound during the pulse check, during the 10 seconds pulse check, not more than this. You may put the probe if you have significant RV strain. This is massive PE or high risk PE. If the flat RV or LV, this is severe hypovolemia. If you assess the pericardium and you found that there is large pericardial effusion or tamponade, this is another sign of or cause of obstructive shock. Or you move up to the lung fields and you assess the lung sliding, you found that there is evidence of tension pneumo, another cause of obstructive shock, or you assess B lines and you need further assessment. So again here, how helpful is the cause protocol during the CPR? Now let's move to the next part in our lecture today, which is the solving the hemodynamic bubble when we face it to assess or to have a practical approach in managing patient with undifferentiated shock. Should you use this dynamic? Should you use static parameters, or should you combine both? What's the advantages of dynamic? What's the advantage of the static? What are the evidence-based tells you about using either dynamic or static to trying to solve the hemodynamic bubble? And this is the hemodynamic bubble when we are dealing with patient in ICU or is critically ill or whatever, either medical or surgical or neurocritical care ICUs. You have to monitor the patient non-invasively, and of course sometimes you have to answer that or to solve the puzzle with some invasive tool. So starting with the clinical, with the hemodynamic monitors, non-invasive, with the hemodynamic monitors, with more sophisticated hemodynamic parameters, you have to solve the puzzle, because at the end, if you are managing patient with undifferentiated shock, it's really puzzle to identify what is exactly the cause of shock, so I can apply my diagnostic tools, and according to my diagnostic tools, my management will start. So your rule here is to put the missing link in this puzzle, so you will solve the puzzle. So I know it's a very rich area that the hemodynamic monitoring in critically ill patients is very rich with the data. But again, for the intensivist, he should be at least familiar with the basics. Then he moves to the advanced part of the hemodynamic monitoring. And also maybe inshallah ta'ala in the curriculum we can put a calendar for some lectures about the basic hemodynamic monitoring, then a second part which is the advanced hemodynamic monitoring. What's the aim from this? It's to solve this puzzle. طيب, to solve the hemodynamic bubble, you have to put a criteria for this hemodynamic tool. You have different tools in your hand, either non-invasive or invasive. But this tool should satisfy you with some accuracy, should at least non-invasive, simple, and cheap, done anywhere, anytime, quick and reproducible. These are the ideal criteria for the hemodynamic tool or the hemodynamic intervention that will help you to solve the puzzle. It should be accurate as much as you can. It should be non-invasive. If it's not available and you have invasive, why not? But we prefer to be non-invasive because we are looking for the ideal. Should be simple, not sophisticated. Should be cheap. Also can be done anywhere, anytime, either in the ICU or in ER, or even bedside if you are in bed surge. And also it should be quick. This does not waste your time, and reproducible. You can repeat it at any time. According to this, what we expect from any hemodynamic monitoring system, irrespective to the name, irrespective to the brand, irrespective to the company you provide, you need to have at least 3 parameters, essential parameters you are expecting from any hemodynamic monitoring system to provide you. What these 3 essential parameters: the cardiac output, the fluid responsiveness, and resuscitation endpoints. So under all circumstances, for any hemodynamic monitoring system, again, irrespective of the name, I'm expecting from this monitoring system to measure accurately the cardiac output first. Number 2, to tell me is my patient is fluid responsive or unresponsive. Number 3, can or cannot tell me when to stop, or what we call it, the resuscitation endpoints. Here is a summary about the dynamic parameters are for fluid responsiveness. We have many monitoring system, multiple monitoring system available in the market, but the principle, it should be clear for all of our intensivists. Are you assessing a systolic pressure variation, or assessing pulse pressure variation, or stroke volume variation, or plethysmography variability index, or BVI, or using the PLR or passive leg raising? Under each of this principal mechanism, you may have a lot. So you don't need to have all these tools or this monitoring system in your ICU, just one or two on maximum. So you need the principle. Either you are having, for example, the BICO, so you are assessing pulse pressure variation, or you have NECOM, you have the Vigilio, or whatever you have, and the available tool in your ICU. But again, it's a tool that will help you with some limitation, with some advantage, with some disadvantage. So you have to know the principle, the mechanism, the advantages, the disadvantages of this hemodynamic or dynamic parameters. Why? Because it will tell you when to give fluid or not to give fluid. For example, if I'm familiar with, as I show you previously in one of the case vignettes, is the systolic pressure or systolic pressure variation, and this is by eyeballing through assessing the arterial line waveform. So simply, if you have a line form, you have to have an idea how can I assess the SPV or systolic pressure variation or pulse pressure variation. So pulse pressure variation, again, with a more advanced monitoring system like PICO for stroke volume variation, like PICO or LEDICO or PRAM, Vigilio. Again, it's a tool that will help you, but you at the end you should know when to use, what's its own limitations. These are most of the common tools that we have it in the ICUs for hemodynamic monitoring, like Swan-Ganz, the NECOM for plethysmography or bioreactants or bioimpedance, the BICO using the pulse contour analysis, LEDICO, the flow track, and PRAM. So those for BICO, LEDICO, flow track, or PRAM, they use what's called pulse contour analysis. And for Doppler or for echocardiography, you assess the VTI in the RV and LVOT, which is for people who are familiar with echocardiography, they can use it commonly bedside. Each of these parameters or dynamic parameters, they have its own advantages, its own disadvantages, and there is certain parameters here added to assessment. Some of them are invasive, and some of them they need assessing, putting a central line or special arterial catheters, or like Swan-Ganz, you have to have the Swan catheter ends for people who are working with cardiac surgery ICU. If you want to ask yourself when I'm assessing the fluid responsiveness, because now you are talking about the preload, so for the RV, or you can assess the LV with you during the fluid responsiveness assessment. So here you are dealing with either static or dynamic. So for example, here, if you use the passive leg raise or the end expiratory occlusion test with cardiac output measurement, so you are ideal here, because you are assessing preload and afterload. You are assessing RV and LV. While if you are assessing pulse pressure variation, you cannot look ideally for the RV, Also for IVC ultrasound, when you want to assess the inferior vena cava diameter, either in spontaneously breathing patients or mechanically ventilated patients, it's one of the dynamic parameters, but again, you are assessing the RV or preload only. While for CVB, it's CVB measurement or right atrial pressure measurement. Again, it's a static, not dynamic, has many fallacies, especially if patient has tricuspid regurg or have right atrial dilatation or has he is mechanically ventilated with high PEEP. So again, it's a static parameters we cannot rely on when using one of these static parameters. And again, if you are using the static parameters like CVB measurement, you are blind about the LV. You don't know the LV. You can push fluids, then look for the trend, but you are not blind about. But when you combine the cardiac output measurement, whatever the tool you use, now you are looking for both RV and LV. This is how can the fluid responsiveness tool that you have or the parameter can be ideal for you. And as I told you, none of these dynamic parameters is free of limitations. Each one has its own advantages and its own limitations. For example, if you look for the pulse pressure variation or BPV, you have to have the patient should be in sinus rhythm, should be ventilated with low tidal volume. The sternotomy, or sorry, the thorax should not be open, and the patient should be passively breathing. So it has its own prerequisites to have a good sensitivity and specificity. Now, moving to the important question tonight, is your patient or is my patient is fluid responsive or not? So before going to a simplified algorithm to answer this, so just let's to ask ourselves, how many of critically ill patients in general are fluid responsive? It's a very important question, was answered since long time, and we found that they found that about 50%, only 50% of patients in ICU or critical ill patients, they responded to fluid administration. And how can you respond to this, or sorry, to assess this? By cardiac output is according to the tool you use to measure the cardiac output. So only 52% of the critical ill patients are fluid responder. The rest are non-responder. So this is important to tell you. You have to know exactly where I am and how can I identify this group of patients who are fluid responder. And this is my rule, is to tell either the patient responder or non-responder. This is the schematic decision tool that will help you to answer this question. So if you want to answer the question, is my patient is fluid responsive or not? So you have to ask 4 questions. So the question is my patient is fluid responder or not? Yes, I have to ask this. Then the next, I will ask 4 sub questions. First, if the patient is intubated, and if he's intubated, synchronized with the ventilator, yes or no? This is the first question. Second question, is the patient in normal sinus rhythm or has atrial fibrillation or irregular rhythm? Third, if he is intubated and synchronized with the vent, is the tidal volume equal or more than 8 cc per kg or not? Fourth, the ratio of the heart rate to respiratory rate is more than 3.6. Those are the sub questions you want to answer. If the answer of those 4 are yes, so the tool you will use it is pulse pressure variation or systolic pressure variation. And the cutoff or the endpoint is that more than 15% in mechanically ventilated patient if the percentage is more than 15% of the pulse pressure variation. So in mechanically ventilated, so it means that the patient is fluid responder and give fluids. If less than this, it means that the patient is non-fluid responder, do not give fluid. In in a spontaneously breathing patient, it has its own limitation, but the ratio is less, or the value or the cutoff value is less if more than 13%. So 13% in spontaneously breathing patients, more than 15% in mechanically ventilated patients. This is for both for BBV or SPV. Pulse pressure variation, systolic pressure variation. More than this, patient is fluid responder. Less than this, patient is non-responder. طيب, if the answers of those four by no, so now patient is non-intubated, he's having atrial fibrillation, or is intubated and not synchronized, he is now ventilated with low tidal volume ventilation, and the heart rate to respiratory rate less than 3.6. So the answer here is no. So the next question will, can you have a lock in the IVC in the inferior vena cava by the sub-xiphoid space or not? Can you examine the inferior vena cava or not to assess the collapsibility, the distensibility, or the distensibility or collapsibility index or indices? So if the answer yes, I can, so you apply the inferior vena cava ultrasound measurement and you evaluate the collapsibility of the IVC or the collapsibility index or the distensibility index. If the answer is no, so here is the role of BLR or passive leg raise or leg. Here is the answer, sorry, the fluid administration or the role of a point of care ultrasound for fluid resuscitation to guide you using the inferior vena cava and the lung ultrasound. If you are familiar with using this, so of course you are familiar now with assessing the IVC to assess the collapsibility or the distensibility or collapsibility index. So first, if the patient is underfilled with the diameter is less than 1.5, so it means that the patient is fluid responder, you give the fluids, mainly crystalloids. If it is between more than 1.5 to 2.5 as a diameter, so you lock if the patient is intubated or non-intubated. If intubated and passively breathing, he is well synchronized, so you use the distensibility index and the ratio here or the cutoff more than 12%. If the patient is triggering or not synchronized with the vent, he go with the algorithm for the non-intubated. So you go for the lung ultrasound here. So we started with the IVC measurement. Here we go for assessing the lung ultrasound profile, A profile or B profile. So if A profile predominance, so here you go with the fluid test, as it may help or it may unlikely to harm to consider the crystalloids if you have A profile here, because the patient is lungs are well aerated, so you go with the fluid challenge. If it's a P profile predominance, so here the patient is fluid restricted, you will hold the giving the crystalloids and you apply the vasoactive or vasopressor support. This is regarding the IVC and the lung ultrasound. But while if the IVC is distended more than 2.5 and non-collapsible or non-varying IVC, this is will support also to hold the giving fluids and you apply the vasopressors, طبعا with certain limitations. Here is the demonstration of the BLR or passive leg raising. How can we do it? It's a very simple technique. Usually you start with 45 degree position, and you check the baseline cardiac output with the tool that you have it, like if you have the pulse contour analysis, then you measure the or the Swan-Ganz, for example, whatever the tool you have, you measure the baseline cardiac output. Then you, after that, the next step, you put the patient supine with the leg elevated for 1 to 3 minutes, and you recheck the cardiac output for positive response. Adhere to those two steps of positive or negative passive raise for assessing the fluid responder. Then the third, you will end up by returning to the baseline position, and you give the fluid bolus if you found that there is a significant increase of the cardiac output, and here you consider the patient is fluid responder. But if the answer is no, of course, you return the patient and you will not give fluids. Here is the tool you should combine with the passive leg raise. So the passive leg raise per se alone is not helpful, but you have to combine the PLR or the passive leg raise with one of these tools, which is the pulse pressure waveform of the arterial tracing, the stroke volume variation through the pulse contour analysis, or esophageal Doppler, or LVT or VTI using the transthoracic echo, or the cardiac output, cardiac indices through also the pulse contour analysis of esophageal Doppler or the VTI. And each of these tools has its own cutoff value, as I told you, to tell you there is a threshold for predicting the fluid responsive. So you have to be aware about the threshold for predicting the volume responsive or fluid responsive after using with the passive leg raise or PLR. Now we are coming to conclude about the hemodynamic tips. Remember, it's very important paradigm right now in the ICU, which is less is more. If you have the tool that can tell you the answer with the criteria we put it or the prerequisite, so you apply less is more. So this is a paradigm shift nowadays in ICU, which is less is more. Common shock pathologists usually hate liberal fluid resuscitation. So after you reach the resuscitation with the fluids, after you assess the fluid responsive, after you resuscitate the empty pipes, so be restrictive and prudent. Also, when you want to choose the ideal or the ideal fluid to resuscitate with, you usually use the buffered or balanced crystallite over the unbalanced crystallite solutions. And also don't follow what's called lact bolus. What does lact bolus? If you have high lactate, it means that I give fluids. Be in your mind that not each figure of high lactate means that the patient should be bolus with fluids. You have to know objectively, not subjectively, that the patient needs fluids before giving the bolus. And remember that the fluid blanket, same fluid blanket, does not fit all. What does it mean? For example, in septic patients, the Surviving Sepsis campaign are telling you give 30 ml per kg of body weight during the first hour bundle. But this number or this value or this amount or this fluid blanket does not fit for all. For example, for morbidly obese, if patient is morbidly obese, are you going to give him only 30 ml per kg? For patient with endothelial disease who's anuric on dialysis, are you going to give him this amount of fluid? Patient who has mixed shock with congestive heart failure, are you going to give him the same amount of fluid? Patient with massive PE and his RV pressure is high and he is presenting you with shock, are you going to give him same amount of fluids? So remember that the fluid blanket does not fit all. So this is why it's important and crucial to have an idea if this patient or is your patient fluid responder or a non-fluid responder. Does he need fluids or he does not need fluid? Are you adding a benefit or are you adding a harm? So CVB measurement is not enough, lactate is not enough, you have a package of data around or in your hand to answer your question. Again, you have to be goal-directed with fluid resuscitation. What does it mean, goal-directed? You have to assess during the resuscitation the increment or the plateauing of vitals, the dynamics, the echo parameters, the transthoracic echo to tell you the VTI, or you have another tool bedside to measure the cardiac output and other indices when you use the passive leg raise, any change in the vitals if you are giving fluids. So you have to look for the heart rate, for the blood pressure, for the MAP, for the urine output. For fluid challenges, usually if you are gonna use fluid boluses, you do fluid challenges to avoid the fluids when there is no benefit. So nowadays, maintenance of the eye fluids is not the ideal practice in some patients. And when you use the BLR, usually we use it, for example, with fluid challenges to tell you should you give or you should not give. And the last word is not said yet, that dry and vasopressors. So for example, in septic patients or hypotensive patient for hypovolemic or distributive shock, should you use fluid first to target and you delay the vasopressors, or you should combine? Many of the literature now, they are recommending that you combine both. Why you combine both? Because each time you delay maintaining the MAP or maintaining the perfusion pressure, the sequelae of acute kidney injury and cerebral hypoperfusion will ensure quickly. So once you start resuscitation with the tool you have, now it's your rule. Should I give fluid or should I not? So I may start using the tool that it will tell me the patient should benefit from fluids. So I'm giving fluids, vasopressors. Then once I stabilize, I fill the pipes, or I will go back step one, and I will ask myself when I can de-escalate to de-resuscitate with the endpoints. Many patients may develop AKI and multi-organ failure, of course, on vasopressors, when in fact you could not benefit from broadened fluid resuscitation. So remember this, for over-resuscitation, adding harm, under-resuscitation is also adding harm. So be wise, be broadened. What about the vasopressors? Usually use the norepinephrine as the first line vasoactive agent. Add vasopressin as a second line agent over titrating the norepinephrine dose if you are targeting MAB and cannot be achieved by the norepinephrine alone. So the first line, this apply for septic shock, usually according to the Surviving Sepsis Campaign guidelines, even from the previous version and the current version in 2021. So norepinephrine is the first line of vasoactive. You add vasopressin as a second line or a second agent when you reach a higher dose of norepinephrine. What does it mean, higher dose? Usually more than 0.25 microgram per kg per minute. If you reach 0.25 microgram per kg per minute of norepinephrine and you did not achieve the target MAP, so this is the role of the second vasopressor or second line agent, which is the vasopressin. You will titrate usually the vasoactive agents to target the MAP of equal or more to 65 millimeter mercury. But remember, patient with chronic hypertension, and the same blanket does not fit all. So you aim higher than 70 or 80 on patient with chronic hypertension. You can use the dobutamine in patient with low central venous saturation or in the presence of cardiac dysfunction and persistent hypoperfusion like hyperlactatemia or low central venous saturation or mixed venous saturation, despite you resuscitated with the fluids and norepinephrine, but still there is an evidence of cardiac dysfunction and persistent hypoperfusion in terms of low central venous saturation or high lactate, so you can use the dobutamine. Also use what we call a shock reversal dose of steroids, which is the hydrocortisone 50 milligram Q6 or 100 Q8, so between 200 to 300 milligram per day to a patient who is in high vasopressor support or combined norepinephrine and vasopressin, and they found this dose 5 to 7 days as a shock reversal. It can help you to shorten the duration of shock and shorten the duration of vasopressor. The next question, can you use the vasopressor in peripheral line? Yes, you can use pressors in peripheral line, especially in circumstances when you cannot put the central line immediately. When the vasopressors use expected to be short, yani for 2-3 hours to prepare yourself. When the CVC insertion or central venous line insertion is difficult, especially in morbidly obese patients or PERM, or when it's not visible, or you may have shortage of the catheters, or if you are waiting for providing the CVC, may compromise the patient care, and patient is in severe shock states. Where to put the peripheral line? Usually it's external jugular vein, or you can use the forearm or the upper arm veins. طبعا contralateral on the other side to the blood pressure cuff. Avoid the antecubital fossa. Avoid the lines for next to joints or tendons or nerves, and avoid the lumps with AV fistula. Type, how long should you use the vasopressors, either Levophed or epinephrine or vasopressin in peripheral line? Maximum, according to most of the literature, maximum you should not extend beyond 6 hours, maximum 6 hours. طبعا point of care ultrasound may help you to confirm the vein diameter. Usually the diameter of the vein, of the peripheral vein, should be more than 5 millimeter. And the minimum gauge is 20 or more, so 18 or 20 or 16 if feasible, but do not use vasopressors and gauge 20 or lesser. Also, you have to ensure blood return from the peripheral line prior to the administration. You have to label the line. It's dedicated for vasopressors. You should not give fluid boluses or antibiotics or other medications with this line. Each peripheral line should be used only for one vasopressors. And if multiple vasopressors are required for patient care, of course, central line is mandated. And no other medication should be used in the peripheral line until you get the central line. Here is the targets and the endpoints. When you continue the resuscitation, you have to ask yourself, when I stop, or where is my targets? So my target, your target is, first of all, is a phase focus. You have 4 phases: phase of salvage, phase of optimization, phase of stabilization. Then once you reach the salvage, the optimization, the stabilization, you start the de-escalation. And what does it mean by de-escalation? Is wean from vasoactive, and you can achieve the negative fluid balance after you started the resuscitation. And these are the aim, or what we call it, phase focus or phase oriented for the targets and the endpoints. And for endpoints of resuscitation, usually we have in our hands many of the parameters or endpoints to assess and to tell you when to stop the resuscitation, or what are the endpoints of your resuscitation. And these tools, either traditional or something new, either acute resuscitation endpoints or ongoing, either static or dynamic tool, they will use. You will use global or end organ. So for the endpoints, when exactly to stop, it's, as I told you, after you finish with the focus phase, or sorry, with the phase focused or the phase oriented, the previous 3 phases. Then here you have the clinical assessment as endpoints like the mentation, skin perfusion, the heart rate, the blood pressure, the urine output, the shock index, pressure. These are clinical indices. Moreover, you may have resuscitation endpoints like the blood gases, the pH, the serum lactate, central venous saturation. If you have the echo and you are measuring the VTI or the another tool to assess the pulse contour, or the pulse contour analysis to tell you the stroke volume or the cardiac output. And last but not the least is to sum up tonight our presentation with take-home messages. Be aware about the common shock pitfall that we presented in part 1. The diagnostic algorithms for shock usually work best among patients with single disease process who are usually normal as baseline, but does not work well in patients with mixed type of shock. Usually when you face patient with undifferentiated hypotension or undifferentiated shock, please widen your differential diagnosis and do not miss the mixed shock type or the overlap syndrome. And you have to put a high index of suspicion for cytokine release syndrome, myopericarditis, and post-intubation hypotension, especially we are in the era of COVID. The goal of your resuscitation of crashing patient or patient with undifferentiated shock is to maximize the survival and, of course, to minimize the morbidity by using objective, not subjective hemodynamic tools, as well as the physiologic variables to guide your therapy. The first few hours are vital during the resuscitation to minimize the organ failure and increasing the mortality. And please be goal-directed with the fluid resuscitation when you use the passive leg raise, the change of vitals, the IVs or inferior vena cava dynamics, as well as the transthoracic echo for assessing the cardiac output and the other hemodynamic parameters. Till now, there is no therapeutic endpoint is universally effective. It's a package, not a single tool. So use starting from clinical, ending up by the most sophisticated tool that you have. And remember, less is more, and the same fluid blanket does not fit all. At the end, be prudent. Remember that you should not add harm. And as I told you, one size does not fit all. Thank you. Jazakumullah khair. I may stop here. I think I completed now almost 1 hour, 10 minutes. I'm ready for questions. I think it's too late now to present the case scenarios. I may send it for you, inshallah ta'ala, on the WhatsApp or to our Professor Dr. Hassan later on for the cases, because now we are about beyond the time.
ممكن نعملها شورت في المرات القادمة برضه.
بإذن الله تعالى.
هيحبوا الكيس سيناريو دي حاجة براكتيكال أو انتراكتيف هناخدها في جلسة كمان. دلوقتي بس ال 5 أو 10 minutes اللي هم يعني فيهم نفس دلوقتي يسألوا مين اللي هيتكلم. في ناس بتقول لك دي محاضرة رائعة يا دكتور عادل وألف شكر وجزاك الله كل خير من ناس آخر.
الله يكرمك.
طب ما حدش يسأل بقى يا جماعة، عايزين أسئلة. حد في حاجة مش واضحة، إحنا مش في امتحان، حاجة مش واضحة.
في هنا سؤال دكتور حسن. في سؤال دكتور حسن على الشات. I think from our colleague under the name of Adel. بيقول what about the IVC from the angle zone 4. طبعا احنا as we told you for assessing the IVC from zone 4 or the assessing the IVC, it depends if the patient is spontaneously breathing, if you remember, or the patient is mechanically ventilated. So if he's mechanically ventilated and you are able to assess the diameter, I show you in the paragraph, if I can return back the slide just for your reminder, because you may miss it. Here is the slide regarding the use of the IVC, and let's just to skip and see the algorithm by using, because this question is important one. Here is the just I will highlight it here. Yes, this is the one. Yes. So here from this slide, you can get the answer. Here is by using the IVC, the solid parameter of the measurement here is not sometimes very useful. So, for example, in patients who are intubated, then you have to paralyze the patient, or the patient should be deeply sedated, so you can assess the distensibility index, not the collapsibility index. For a patient is triggering or patient spontaneously breathing, you are using the collapsibility index. And again, as I told you, sometimes it's not visible, especially in surgical patient, who patient has Webel or patient has tense ascites, sometimes is not visible to, or obese patients sometimes not visible, so you have to use more than one tool to assess.
انا بقى ليا سؤال. انت قلت في الالجوريزم بتاع الارست بنبص على اللي اسمه بلو، وانا مش فاكر اسمه ايه، قلت بنبص على رايت فنتريكال سترين. تقصد ايه بالسترين؟ السترين اللي موجود في جهاز الايكو، ولا سترين يعني دايليتد، ولا سترين؟
لا مظبوط، شكرا دكتور حسن. السترين اللي نقصده الساينز اوف ار في سترين to assess the evidence of pulmonary embolism. So when I am looking for cardiac arrest to secondary to pulmonary embolism, so I'm looking for signs of RV, like acute pulmonary hypertension, acute RV dilatation, pushing of the septum to the other side. One common sign, we call it McConnell sign, which is the hypocontractile RV sparing the LV, or 60/60 PT over the PDH indices. So this is, we call it RV, evidence of RV strain.
في سؤال واحد بيسألك بيقول لك في واحد قال انت نجم في سماء الطب.
الله يكرمه، الله يجزيه الخير. الله يخليك.
في واحد بيسأل في رول للميدودرين فور ويننج فروم فازوبريسور؟ الميدودرين له اي رول فور ويننگ فروم فازوبريسور؟
There is not evidence based till now. Some people, when they label patient as they are we call it pressure dependent, they are trying to use the midodrine. Some they got good results, but it's a weak evidence. There is some evidence now in patients who are cardiorenal syndrome. They are using midodrine. When they label him as cardiorenal syndrome.
No, your ultrasound device in our ER treating room, so the assessment patient is very difficult and the query, but thank you for ultrasound technique, دكتور عادل.
طبعا it's not available دكتورة اسراء، صحيح، هي انا عندك حق، بس يعني الان البورتبل الترا ساوند او حتى الايكو، الناس اللي عندها ايكو ماشين دي have to be familiar with، لان الان زي ما انتم شايفين it's a very simple quick tool you can get it quickly. طبعا احنا زمان ما كانش عندنا هذه التول، زمان كنا بنعتمد على صح لازال our clinical some labs, but again our most of our patients are ventilated, most of our patients they have tricuspid regurg, they are on high PEEP, so to tell me exactly if the patient is fluid responder or not, طبعا you have to have some objective rather than subjective data. لكن طبعا عذرك معك يعني.
اخر حاجه بقى، في واحد بيسال على تبعت له محاضره. احنا دلوقتي عاملين يوتيوب، المحاضره اللي فاتت متسجله والمحاضره المسجله هينزلوا على اليوتيوب خلال اسابيع. والكيس سيناريو خليها ما تبقى الاول، لو واحد عايز تبعت اناني بيقول لك ابعتها لي على الواتس بتاعه، لا احنا هنقولها للجميع المره الجايه او اللي بعدها، وبعدين ايه اللي عايز يحطها له الدكتور عادل على الواتس هيحطها له. تمام، اعتقد ان ده enough time عشان الساعه داخله على 11 ومش عايزينكم تزهقوا، ومتشكرين جدا دكتور عادل على المحاضره القيمه بتاعتك.
دكتور حسن، تحت امرك دكتور حسن، شكرا جزيلا وتصبحوا على كل خير.
شكرا دكتور حسن، شكرا دكتور خير، دكتور عادل.